A family cares for you and has your back. The same is true for the Venue family, developed specifically for point-of-care medicine and a wide range of environments. The AI-enabled Venue family is flexible and supports the needs of clinicians across all points of care. An intuitive interface and a common platform across systems help drive consistency from user to user. Automated and advanced clinical tools enable fast assessments to simplify the complex, support your life-saving decisions, and help you monitor patient progress. The Venue family is designed to enable fast patient assessments with AI tools to give you the information you need now. Be confident in what you are seeing, regardless of the environment you are in or the patient you are scanning. Designed for continuity across 3 systems, the Venue family's platform with interchangeable probes facilitates easy onboarding and training for a consistent user experience. Easy to clean, smooth, and seamless surfaces support infection control efforts. The Venue family delivers simple, fast, precise ultrasound for improved patient outcomes.
Welcome everyone to our Point of Care Ultrasound POCUS webinar series on the topic Measure and Maneuver, how to determine fluid responsiveness dynamically using simple to do point of care ultrasound applications by Dr. Romulo Babasa. My name is Kamarul from GE Healthcare, and today's webinar is all about POCUS. We will be doing a lot of webinar series like this in the future. As you can see on screen, this was the webinar we've done before with Dr. Srikar Adhikari. So I will be posting QR codes for you to scan. This will lead you to our website, and we will be sending you updates for the future webinars on this website. I will post the QR code again at the end of this webinar later on, so do scan it and to get further updates and also more information on the ultrasound we offer. So before I introduce our speaker, let me introduce myself. My name is Kamarul from GE Healthcare. I am the Clinical Marketing Manager for Point of Care Ultrasound in Southeast Asian countries or ASEAN. As you can see on screen, I put up my email, my Facebook, and my LinkedIn account. So if you have any questions or inquiries regarding today's webinar or the product you see, feel free to contact me in any platform you are comfortable with. And I would like to take this opportunity to thank all the doctors and healthcare partners that have collaborated with us on so many occasions before the pandemic. Now we have to adapt and do all virtually online as we are doing today. So from the bottom of our heart, we at GE say thank you and do contact me if you wish to collaborate with us on future projects. Alright, so let me now introduce our speaker for today. Dr. Romulo Babasa III has more than 10 years experience focusing on emergency and critical care ultrasound. He graduated from University of Santo Tomas Faculty of Medicine and Surgery in Manila, Philippines, and continued his emergency ultrasound training at the Department of Emergency Medicine, Massachusetts General Hospital, Harvard Medical School in Boston, USA, one of the best medical schools in the world. He is currently the Assistant Head of Department Emergency Medicine at St. Luke's Medical Center, Quezon City, Philippines, and is also the founding President of Philippine Society of Ultrasound in Resuscitation in Emergencies, PSUR. So before I pass it over to Dr. Babasa, let me read out a disclaimer first. This video is solely for educational purposes only. The material and views represented in this recording have originated from the presenter and they do not necessarily reflect those of GE. With that, I pass it over to Dr. Babasa to continue his presentation. Over to you.
Thank you very much, Kamarul, for that wonderful introduction. Welcome, everyone. I'm again Dr. Romulo Babasa III, and I will be lecturing on what I call measure and maneuver. These are simple POCUS applications for evaluating fluid responsiveness. So the objectives for my lecture are the following. Briefly discuss the static and dynamic.
Dr. Babasa, can
Sorry,
you
yes?
share your screen once again?
I'm sorry.
We seem to lose. Yeah.
I'm sorry.
It's okay.
Let me start over. Okay, let me just share screen.
Yep, I see
All
it's
right.
loading up. All right.
Okay, I'm sorry about that.
Okay.
Okay, let me start over again. Again, thank you very much for that wonderful introduction, Kamarul. I'm very sorry for the technical difficulty. I'm Dr. Romulo Babasa III, and again, this is my lecture, Measure and Maneuver, Simple POCUS Applications for Evaluating Fluid Responsiveness. And these are my objectives. Briefly discuss static and dynamic measures used in determining fluid responsiveness. I will briefly discuss the role of POCUS in the evaluation of fluid responsiveness of hemodynamically unstable patients through a case-based method. And lastly, I will discuss limitations and pitfalls of POCUS-guided determination of fluid responsiveness. So before we go into this lecture, we must keep in our minds this particular concept that the IV fluid should be treated as a drug. It is a drug with contraindications and adverse effects. It has dosing with regards to timing, speed, and the cumulative dose when you're giving fluids. There's also duration onto which you should be giving your fluids, and you should stop it when they're no longer the patient is no longer fluid responsive or doesn't feel need the fluids already. And you should be using indices or parameters to signal you to stop. And when in terms of when you're overdosing on the fluid, on the drug, or the patient is fluid overloaded, you should have steps or measures to de-escalate or remove that excessive fluid. There's no better evidence than this particular trial, the FEAST trial, which was done way back in 2011, wherein 3,000 African children with febrile illness were randomized into groups that receive fluid boluses of about 30 ml per kilogram, 20 ml per kilogram, 40 ml per kilogram. What happened was very catastrophic. No? Most of the patients who received fluid boluses had significant increased 48-hour mortality. as compared to those patients that did not receive any fluid boluses. So this just reiterates what I said earlier, that the fluid is actually a drug. It should be monitored when used, and there should be parameters on how long and how much should be given to a patient. Now, the reason why these patients died is mainly because excessive fluid will cause hemodilution, which will reduce oxygen delivery to the tissues, and the excessive amount of chloride in saline fluid will cause metabolic acidosis, which will further impair renal blood flow. The excessive fluid will also cause cerebral edema, which will cause your neurologic effects, and of course, the extravascular lung fluid, or in the form of pulmonary edema, will impair oxygenation, therefore cause deleterious effects on the respiratory physiology of the patient. So that's the reason why fluid kills. Now, how do we prevent those deleterious effects? Now, we have to know and understand the concept of fluid responsiveness and fluid tolerance. Uh, Defining fluid responsiveness, it's classically defined as an improvement of stroke volume by at least 10% after a fluid challenge. So when you give fluid, does the heart beat faster, and if circulation is improved? And then very closely related to that is the concept of fluid tolerance. Fluid tolerance is the volume of fluid that the patient can tolerate without clinically significant side effects. Meaning, if you give fluid, it's up to a threshold wherein that fluid will not cause any adverse effects, just like any other drug. Now, the goal behind these two concepts should be adequate oxygen delivery by maintaining an adequate cardiac output and perfusion pressure. And the physiologic basis behind that would be an intravascular volume expansion. So you're giving fluid to increase the intravascular volume to increase adequate oxygen delivery by maintaining an adequate cardiac output. Now, uh, in order for us to further delineate between fluid responsiveness and fluid tolerance, these are usually the questions that can be answered by these two concepts. For fluid responsiveness, the questions that are asked and can be answered could be: should I give my patient more fluids? And if so, how much and for how long? Another question would be: will the patient improve hemodynamically after giving fluids? Now, your fluid tolerance will usually answer the question: will it lead when you're giving the fluid, will it lead to fluid overload and hurt the patient? And how much fluid can hurt a patient? Now, if we put it into a diagram, not to visually understand these concepts and how they're interrelated to each other, I'm going to borrow from Felipe Rolla, who is an intensivist, this excellent diagram which shows you the relationship between volume responsiveness and volume tolerance in light of volume infusion. As you can see, there's a particular threshold in which the patient will have improvement of cardiac output at a certain threshold or a certain amount of fluid. And when you go beyond this threshold, there will come a time that the patient will no longer be able to tolerate excessive fluid. So this is in healthy individuals or healthy subjects. No? So the volume responsiveness and the volume tolerance are not that close to each other. You can have additional more fluid when you've reached the volume responsiveness threshold that the patient can still tolerate. However, when it goes beyond this threshold, the fluid that you've given the patient will have deleterious effects. Now, it's quite different when the patient is sick or critically ill. Now, there's no distinction between volume responsiveness and volume tolerance. So you'll get to a point that the patient will still be responsive to your volume infusion. However, if you go beyond that point, the patient will no longer be fluid tolerant or volume tolerant, and therefore will have the deleterious effects that I mentioned of fluid overload. So it's very important that we know and determine where exactly that threshold is so that we prevent from going over the threshold of volume tolerance. And the reason for this is based on physiology. Uh, Many of the studies have said that only half of adult patients will actually respond to intravascular fluid expansion, which means out of 10 patients, only 5 of them will have any beneficial effect or beneficial outcome from giving fluid expansion. So, but certainly it still stands that appropriate early fluid resuscitation improves survival. It's also also true that excessive fluid therapy increases mortality. However, in order for us to determine what that threshold is, the physical examination findings and routine monitoring that we're doing, like your vital signs and your PE or auscultation of the lungs, are not enough. Now, this is based on the thresholds that I'm talking about are based on this Frank Starling curve. Now, so we are all quite familiar with this. No, back in med school, it just shows that when you're increasing or you're giving fluid, your cardiac output, your heart in particular, responds to it by increasing contractility and expanding its chambers. However, there will come a point in time when the contraction and the expansion of the heart will reach a threshold wherein it can no longer compensate for any increase in the volume. At that point is at this area of the curve right here. That's where most or half of the people receiving fluid boluses will be able to respond in terms of improved cardiac output and tolerate that fluid. Beyond that curve, point in the curve, these patients will have a plateau of the response and therefore will not be able to tolerate any additional fluid. So, in essence, we have to know this point here. How will we be able to know that when giving fluids, we're already at this point and we have not gone over that point in which the patient will be a fluid intolerant na patient? Now, I'm going to spoil the rest of the lecture to you. There's no dichotomous test that will tell us that there's a test that will tell you that stop giving fluids or still give fluids. No, there's no test like that. It's a holy grail. And I think, and I personally believe that we should stop looking for it because it's not going to happen. Fluid and its effects on the body is a complex interaction with the heart and the lungs and the tissues. So no single dichotomous test will tell you yes or no, but we can certainly try. As of now, in critically ill patients in the ICUs and in some ERs, we're using these hemodynamic variables as predictors on whether the patient is still fluid responsive or fluid tolerant. These are the static variables and the dynamic variables. The static variables are single observations in time, while the dynamic variables are variations in your preload that are evaluated serially. And these are usually as an effect of mechanical ventilation or fluid challenges in spontaneously breathing patients. So the static measures are some of the first indices that were used in the early days. No? These were snapshot measurements of preload. There were single observations in time, and they usually include your heart rate, your blood pressure. But unfortunately, these were parameters that are unreliable in predicting fluid responsiveness. Now, the static measures also, aside from your heart rate and blood pressure, they include your CVP, which is very common. During my medical school days, this was the part and parcel of any patient in shock. No? The monitoring included BP, heart rate, and CVP. Another static measure is pulmonary artery occlusion pressure and left ventricular and diastolic area. Now, for your dynamic measures, these are interactions between your heart and lung, which can be used to assess fluid responsiveness. They are usually physiologic responses to mechanical ventilation or onto transfusions, which I'll discuss later on. These dynamic measures are the best predictors in adults. However, they have paucity of evidence in pediatric patients. Some of the dynamic measures that are being used nowadays are your pulse pressure variation, your respiratory variation in aortic blood flow peak velocity, your passive leg raise induced change in stroke volume, which is a form of autotransfusion, and special mention which will be your inferior vena cava diameter variation, which will be included in my discussion later on. So here's a table that's summarizing all of those measures that I've mentioned. Some of the measures that needs to be given attention to would be your central venous pressure. It's a static measure, but invasive. It needs a pulmonary central catheter in order to measure the right atrial pressure, which becomes a surrogate for your central venous pressure. However, in most studies, and there's a lot of them, more 1,000 studies about CVP, it's actually been affected by a lot of intra and extrathoracic factors like your valvular disease, particularly with the right side of the heart, the arrhythmias, and pathologies in the lung like your pneumothorax. Recently, it's been debunked as a something that can be used to predict fluid responsiveness. However, it's still being used by many clinicians as a surrogate for determining fluid responsiveness. Another measure that I would like to mention is the respiratory variation in aortic blood flow peak velocity, which is a dynamic measure, but it's non-invasive. You derive this by means of Doppler echocardiography. The prerequisite should be that the patient should be in sinus rhythm and of being POCUS or ultrasound or echocardiography based. It's operator dependent, and it's also a very tedious and complicated measurement. First, you have to measure this area of the heart. This is, by the way, a parasternal long axis view of the heart. In order for you to get the respiratory variation in aortic blood flow peak velocity, you should measure the area of this particular part of the heart, which is the aortic outflow tract. You call that the LOVOT area. And then you should get a 5-chamber view of the heart in order for you to measure via pulse wave Doppler the speed of blood flow outside of the left ventricular outflow tract, which is that area. So it consists of tracing the peak flows of this, of the Doppler outcomes. And from that area, from that computation, you'll be deriving your stroke volume. In order to get your cardiac output, you have to multiply the stroke volume, which you got from this formula, with your heart rate, and you'll get the cardiac output. So it's very tedious, lots of steps involved. But the good thing is your GE venue ultrasound actually has an artificial intelligence or AI tool, which consists of an algorithm to calculate the VTI and cardiac output automatically. The VTI is your LVOT. So there's what the result is called the VTI trending result, which will help you determine if the amount of fluid you're giving is actually having an effect on the cardiac output. So a certain increase in your cardiac output while being assessed by this auto VTI tool will be beneficial in telling you when to stop giving fluids or if your fluids are having any positive effect. Now, it definitely reduces the steps of manual measurement, which I outlined a while ago. All right. So, in general, the static measures are not really good predictors, like your heart rate and blood pressure. There's snapshot assessments in time. Okay, but the dynamic variables, even though they are very effective, very accurate, they involve invasive monitoring. They usually involve arterial lines or a central venous catheter. You need expensive equipment in which to hook your arterial lines and your central catheters. Its prerequisites are mechanically ventilated patients so that the respiratory mechanisms are standardized. It's operator dependent on some of the measures that involve echocardiography. There's good evidence in adults, but essentially not in children. So again, this just reiterates that there's no dichotomous test that tells you whether to give fluids or not. And so looking for that one test that will tell you effectively and accurately the fluid responsiveness of a patient is actually a holy grail. Now, what I propose is that we use our point of care ultrasound in order to determine whether a patient is going to be fluid responsive or and fluid tolerant. So I will propose applications that are simple and easy to learn, even if you're a novice sonographer, even if you don't have any high-tech machines, or even if your department or your clinic only has older machines. Definitely, if you don't have any AI tools to use with, but if you have them, use them at all by all means. Um, these applications should be quickly are something that can be quickly performed and quickly interpreted. No, not much computing because I'm really poor in math, and you can eyeball the interpretation quite quickly. And of course, even though they're simple and just interpreted by eyeballing, they still have good sensitivity and specificity, and therefore accuracy in interpreting. So these POCUS-based parameters have been for a long time, have been an emerging point of care critical illness tool. They are dynamic assessments that can be done at the bedside. They are safer interventions. They're easy to learn. they have qualitative and quantitative assessments. Definitely, they're not perfect, but they are very useful, as I will discuss later on. And most of these parameters, these POCUS-based parameters, are mainly used as serial exams and not just one single assessment over time. Furthermore, these POCUS-based parameters are evaluate many components of the effective circulating volume or the volume status of the patient. And these are your pump, tank, and pipes. Your pump relating to your heart or cardiac. Your tank is your lung or your lungs, and the pipes are your IVC and the aorta. And in those three components, you'll be also tackling preload, which is the volume of blood that's going to the right side of your heart before the pulmonary circulation, the contractility of the heart, and of course the afterload, which is the systemic vascular resistance, or essentially your systolic blood pressure. Okay, the components of what I propose to be your focus-based parameters for fluid responsiveness would be your focus cardiac ultrasound, where essentially you'll be looking at the size of the heart and the contractility of the heart. The lung ultrasound, in which you will try to detect the presence of A lines or B lines. The IVC diameter measurement, in which you will evaluate the respiratory variations of inferior vena cava. And lastly, the IJV, or the internal jugular vein diameter, in which you will, similarly to your IVC, will evaluate the respiratory variations of your internal jugular vein. Now, I don't have to outline all the studies that say that focus-based parameters are actually very useful in determining fluid responsiveness and fluid tolerance. It is, and it's attested to by a lot of studies, 1,000 studies, I think. And they simply tell us the same message. Fluid responsiveness evaluation is easily achieved by using simple indices that are derived by POCUS, and these can be used in different clinical situations. Now, these clinical situations I will discuss in with an example of 3 cases that we actually encountered in the ER. So for each case, I will give you the POCUS parameter or the POCUS-based evaluation that I used to evaluate these patients. For case number 1, we have a 47-year-old male patient who has been diagnosed with aspiration pneumonia. He's already intubated and has altered sensorium. So his comorbids are hypertension, diabetes type 2, and a previous MI. So he has a lot of comorbidities. The vital signs are as follows. The BP is 83/44. The cardiac rate is 137. Of course, he's assisted uh, as he is in mechanical ventilation. The temperature is 36.9 and the O2 sat is 96%. Now for PE, he has RALs on the left lung field. And as an initial intervention to this patient, he has received 1 liter of saline wide open, which is fast drip. And after half an hour, the BP was 75/35 and the cardiac rate was 142. So it did not improve after the fluid bolus. So the question here is, does he need more fluids? And if he does, and if you're going to give fluids, what will be your basis on how much fluid you will give? And at what point does this patient will reach the threshold for fluid tolerance? And if he's not, if in order for you to prevent the patient going into fluid overload and having all those deleterious effects that I've mentioned. Okay, so for this case, I'm going to use the inferior vena cava diameter. So as you can see in this clip right here, that's the inferior vena cava. That's the structure before the right atrium. It's a capacitance vessel. It's that big vein that holds all your preload before it goes into the right side of the heart, before it goes to the pulmonary circulation for oxygenation. It's when assessing the inferior vena cava, it's non-invasive, obviously, because you use the ultrasound only. It's something that's easily available and it requires minimal technical expertise. Even novice sonographers can do this. Now, the thing that you have to look for in inferior vena cava is the diameter changes in response to your respiration. So the dictum is, if the IVC diameter increases, that increases the preload and the right atrial filling. Okay, so the inferior vena cava diameter variation is actually favored among the dynamic indices. It's very popular and it's used by almost everyone I know. It's based on lung-heart interaction, specifically in light of respiration, in which transpulmonary pressure during respiration is transmitted to the right heart, and in essence, it also gets transmitted to the IVC because it's connected to it. Now, that variation in your IVC diameter due to the transpulmonary pressure can be used to predict fluid responsiveness. And we have to be familiar of how the IVC behaves during respiration. Now, for spontaneously breathing patients or those that are not in mechanical ventilation, when you inspire, there's increased interpleural pressure, which there's decreased pleural pressure, which allows the heart to expand, and therefore there will be it will allow venous return from IVC, and therefore your IVC will collapse. Now, in expiration, when you're trying to squeeze out air from your lungs, there will be increased in your intrapleural pressure, and therefore the heart will be squeezed and will be unable to expand further, and therefore that will decrease venous return from your IVC, and then in turn the IVC expands. Now, when the patient is in mechanical ventilation, the situation is flipped. Now, when you are inspiring and the mechanical ventilator does the respiration for the patient, there's actual increase in your pleural pressure, which squeezes the heart and limits its expansion, and therefore the venous return is decreased, which expands the IVC. When you expire, when the mechanical ventilator is trying to pull out air from your lungs, the pleural pressure decreases, and therefore it enables the heart to expand, and that will increase your venous return from your IVC, and your IVC in turn collapses. So when you're measuring the variation, you're thinking of the index, and the formula for this. For example, in your collapsibility index in spontaneously breathing patients, you get the maximum expiratory diameter, and then you subtract the minimal diameter upon inspiration, and then you divide it with the maximum or expiratory diameter. For mechanically ventilated patients, you're thinking about distensibility. As you remember from the diagram I showed you, the IVC does not usually collapse. No, it actually distends. So you get the maximum diameter and the minimum diameter. You subtract the minimum diameter from your maximum diameter and divide it by the minimum diameter and multiply it by 100. You'll get the vena cava distensibility or distensibility index. Now, how accurate is or how efficient is your inferior vena cava diameter management in determining fluid responsiveness? A lot of studies out there, hundreds of them. IVC diameter and collapsibility is a valid method, and it's a surrogate for your CVP or central venous pressure. Um, it's they've been trying to push this for so long that they came out with this nifty table right here that tells us that your IVC diameter correlates to certain CVP levels. In particular, and if the diameter of the IVC is 1.5 to 2.5, and there's a collapsibility of about 50%, or the IVC collapses to about 50% of its original diameter, that corresponds to a CVP of 11 to 15. So anything lower than that has means that the patient has increased CVP and therefore will be fluid intolerant. And for patients who have greater than 50% collapsibility index or smaller diameters, these are correlate to lower CVP pressures, and therefore the patient will be fluid tolerant. Now, how about in children? Is the IVC in relation to its correlation with CVP efficient or accurate? Well, unfortunately, it does not. No, but however, the extremes of your IVC diameters, like the very collapsed and the very distended IVC diameter, are still very, very much accurate in determining whether these patients are fluid tolerant or fluid intolerant. So, which means that if you have a very small IVC diameter, you can give fluids in kids. However, if you have a really large or distended IVC, maybe you should stop giving fluids because these patients are already fluid intolerant. Now, summary of all the studies, usually the IVC is a very good predictor of fluid responsiveness in adults. There are controversial evidences in children. The reason for this is that IVC being a surrogate of CVP is not actually directly equal to volume response or volume. It's actually a measure of pressure. So therefore, there's in essence, some of the translation is some of the meaning is lost in the translation. So you're trying to correlate pressure with volume. However, the collapsibility in spontaneously breathing patients are greater than 50% connotes, as I've said, fluid responsive status. Distensibility of your IVC in mechanically ventilated patients of greater than 14 to 18% also connotes fluid responsiveness. The sensitivity and specificity of those findings, for example, those that are approaching 44% collapsibility, it's 93% sensitive and 98% specific, and determining and in terms of accuracy in determining the fluid responsiveness of the patient. This correlates with earlier studies on the estimation of the CVP pressures and the right atrial pressures as correlated to the inspiratory collapse or the collapse or collapsibility of your IVC. As you can see from the study here way back in 1990, the 50% collapse is really the threshold in which it's also accurate for determining responsiveness and also a very accurate index for you to give these patients fluid. Now, in order for us to further understand that concept of collapsibility and its relation to fluid responsiveness, let's put it into a diagram. So as you can see from here, when you're approaching the 50% IVC collapsibility, that's the most accurate index that you can have for determining fluid responsiveness. Okay, so right around that collapsibility index. Now, if your IVC collapsibility is around 20% and below, that's the time that the IVC is not collapsing, so which means that it can no longer accommodate more fluid into the right side of the lung, of the heart, and therefore that patient is fluid intolerant. And for those patients which have really great or big collapses and its diameters, those are the patients that are actually fluid tolerant. Okay. Now, for distensibility, the area around 14 to 18% of the distensibility index, that's the most sensitive and the most specific, approaching 90%, in using it to predict accurately fluid responsiveness. And if you put it again into a diagram, IVC distensibility, if the distension is above 50% and beyond, it's that patient is going to be fluid tolerant. So if the IVC distensibility is about 20% and below, that patient is probably fluid intolerant and should be stopped giving fluids to that patient. Now, most of the studies on IVC distensibility and IVC collapsibility tell us that IVC distensibility is actually the better predictor for your fluid responsiveness, particularly in mechanically ventilated patients. And the collapsibility has controversial evidence. It's usually negative in most of the systematic reviews. However, the extremes of collapsibility, the very distended and the very collapsed, are actually accurate, as I've said previously. So that means if you're going to trust the collapsibility of the IVC, you should trust when it's really collapsed and when it's really distended. So when it's really collapsed, you can give fluid safely, and when it's really distended, you should probably stop giving fluids. Okay, so going back to our case, in case number one, this is the scan of the patient's IVC. As you can see, there's some collapsibility in this clip. So what we did was we took that clip via a subcyphoid view of the IVC in a sagittal plane. As you can see from this image right here, you should be using the curvilinear or the sector probe. You should measure the diameter of the IVC about 2 centimeters from its junction to the heart, to the right atrium, which is around right at this part, or maybe from 1 centimeter from this structure right here, which is the hepatic vein. So usually, most of the people I know use the M mode in measuring the IVC, but I think we should practice some caution here. Definitely, it's going to be very easy. You can visually see the maximum and minimum diameters right here. When you expire, that's the maximum diameter, and when you inspire, that's the minimum diameter. So it's just only a matter of measuring the the diameters of this particular IVC. However, when you're using the M mode, the measurement, the ice pick that you direct the measurement of the ultrasound, it's actually static. It doesn't move, but your IVC actually moves during respiration. So it has a craniocaudal displacement. And therefore, when you're measuring it using the M mode, you're actually measuring two parts of the IVC. So this will result to an inaccurate result, or maybe even an overestimation and an underestimation sometimes. So what I usually do is that I record it uh, in Cine and then pause it in the maximum diameter, measure it using the calipers, and then run it again and pause it at the most minimum or smallest diameter and measure it again with the calipers, and then I compute it. So for your GE, for the GE venue users, you have your auto IVC tool, which is again an AI tool. It measures the IVC quite automatically. So it also compensates for that craniocaudal displacement. So it's very, very useful. You don't have to think that maybe you're not measuring on the same place on the IVC. So it definitely reduces the steps and the keystrokes that are involved in measuring the IVC. So you use it if your machine has one, and it's usually in the GE venue. So for our case, the distensibility index, I got a maximum diameter of 1.45 and the minimum diameter is 1.18. Using this formula right here, I was able to derive this result right here, which is 0.22, and multiply it by 100, you get 22% distensibility. Now going back to the diagram, when the distensibility is greater than 20%, right? That means the patient is still fluid tolerant and you should be giving, and you should be able to give fluid safely to this patient. And that's what actually I did on this patient. I gave another 500 cc's of IV fluid, and then I remeasured the IVC collapsibility index after 30 minutes. The distensibility index decreased to about 12%. And so therefore, but the vital signs improved. There's the BP improved 110/70 from a previous of 75 and 35. So this patient had an uneventful course in the ER and was eventually transported to the ICU, where he recovered quite nicely. Okay, so the pros and cons of using IVC for fluid responsiveness. It's easy to learn and do. It's non-invasive, definitely. It's a great CVP surrogate. It has its measurement caveats, especially in terms of the craniocaudal displacement. It's unfortunately not accurate in spontaneously breathing patients. The evidence is really, really small. Uh, but for this patient, like the one we just discussed, is a intubated patient and mechanical ventilation, the distensibility index is actually very accurate. And if you're going to use it alone, no, without any comparison or correlation with other indices, you should correlate it always with your clinical findings, like your physical examination findings, which determine whether the patient is clinically dry or wet. Now, for our case number two, we have a 56-year-old male who's obese, hypertensive, diabetic, and has no heart disease. So right off the bat, we can see here, well, you can definitely not use the IVC on this patient. Um, he has abdominal pain, he has vomiting, he has urinary frequency, and has been diagnosed with urosepsis. So the vital signs are as follows: the BP is low, 75/50, the cardiac rate is tachycardic at 125, the respiratory rate is also high at 25, the temperature is 36.3, but the O2 stats are not bad, about 98%. The creatinine is already elevated, so he's going into acute kidney injury. So because of that, he received 2 liters of saline. So 2 liters of saline, and after an hour, the BP was 80/50, and the cardiac rate was 120 per minute. So there's not much improvement. Okay, so the question is, does he need more fluids after giving 2 liters? All right. So again, right off the bat, you cannot use the IVC on this patient because of the protuberant abdomen. So what I propose for this case is that I'm going to use an alternative to the IVC, which is your internal jugular vein. So the IVC can occasionally be not assessed in certain patients, mainly because of, for example, in this case, body habitus or the presence of bowel gas or ascites, and maybe the patient has been operated on and there's surgical dressing over that area, and you don't have access to the IVC. So the most common method of evaluating the IJV, or the internal jugular vein, is the change in diameter respiration, which is similar to your IVC collapsibility. And definitely, because the IJV, or the internal jugular vein, is static, it doesn't move with your respiration, you can use the M mode. Now, there's a lot of literature out there that attests to the IJ as a great surrogate for CVP, and also for determining fluid tolerance and fluid responsiveness. This particular paper right here tells us that about a 7 millimeter mean diameter of your IJ corresponds to CVP levels of less than 10 centimeters. For IJV diameters of 12.5 millimeters and above, they correlate to about a CVP of greater than 10 centimeters water. So therefore, if you have a bigger IJ, better stop giving fluids, because these patients are going to be intolerant. Here's another paper that tells us that there's good correlation with JVP if you're not using the maximum and minimum diameter. If you're just using the anterior posterior diameter on an isolated way, this can have good correlation with CVP in spontaneously bleeding patients. Here's another study which was done during that era of the early goal-directed therapy of your sepsis management, which has already been debunked. They used the internal jugular vein to tell them, or to signal them, that you'd already achieved your target CVP of 8 millimeters. And what they did was they used the IJV aspect ratio, the weight divided by the height of the diameter of the IJV, which will they uh, set at 0.84, which corresponds to a CVP of 8 millimeters. So when you reach that, when you give fluids and your IJ aspect ratio is already 0.84, you've already reached this goal of 8 millimeters mercury for your CVP in early goal-directed therapy of sepsis. Now, I said that the IJ is actually a good replacement or alternative to your IVC. This is the one of the papers that tells us that the respiratory variation of your internal jugular vein in mechanically ventilated patients showed good correlation and agreement with your IVC. And if you're using it in septic patients who are mechanically or in mechanical ventilation, the IGV can also be used in the form of distensibility index, much like your IVC. And IVJV distensibility of about 18% and above is 80% sensitive and 95% specific to predict fluid responsiveness. So again, if you're going to use collapsibility of the IJ, a collapsibility of greater than 19% and beyond, that's 73 to 83% sensitive and specific to predict CVP. So if we're going to put all of that data into a diagram in order for us to visually understand what we just went through, so your IGV collapsibility, if it approaches anywhere between 20% and below, those patients are fluid intolerant. So you should not be giving fluids to them already. Now, for those patients that have more than 50% collapsibility and beyond, these are the patients that you can safely give fluids because they're fluid tolerant and their CVPs are quite low. Okay, so going back to the case, how did we arrive at measuring the IJ? The patient should be in a supine position with the head at a neutral position, should not be tilting the head in order to not compress on the IJ. You should be using a linear probe, and it should be positioned 2 centimeters above the level of the clavicle right here. When you see the image, in order for you to determine which is the IgA in the carotid, you can use your color flow. However, looking at it, the IgA is usually the bigger structure in most instances. It's oblong shape and it collapses, while the carotid is much rounder and has thicker walls and it's pulsatile. So you use your M mode to determine the maximum and minimum diameter with regards to variation brought about by respiration. And for our case, for case number 2, this was the clip of there. As you can see, there's not much collapsibility, right? So there's very, very minimal collapsibility. and I was able to measure it. The maximum diameter is 1.49. The minimum diameter is 1.35. I'm sorry. So using this formula right here, I was able to derive this result right here, which is 9.3%. So 99.3%, that correlates to a higher CVP, and therefore the patient is already fluid intolerant. So for this case, we stop fluids, we start the patient on a norepinephrine drip, and the vital signs improved to BP of 125 or 68, 108 cardiac rate, OTSATs from 99% from previous of 80 over 50, 120 per minute, and 97% OTSATs. So this patient was eventually admitted to the ICU with stable vital signs. So pros and cons of using your IJV. It's similar to your IVC. It's easy to perform. It's a static organ, so our vessel, which means you can use your M mode. It's non-invasive, obviously. It's a great surrogate for your CVP as well as your IVC. And if you're experienced enough and quite an expert on diastology, because of its juxtaposition to the internal carotid artery, you can use carotid artery indices to get a clear picture of the right and left side fluid status of the heart and get a more accurate picture of fluid responsiveness. However, it doesn't have that many studies wherein it gives great evidence on using it in patients with right-sided heart pathology, like for example, in those with right-sided heart failure, and in those patients with valvulopathies, or maybe even in those patients with pulmonary hypertension. Now, for case number 3, which is the most interesting case, this happened quite recently, about in June, I think. I was with my resident, Dr. Rose Evangelista. We received a patient who was a 35-year-old male, CKD5 patient on hemodialysis 3 times a week. So he's hypertensive but non-diabetic, has no cardiac disease. So must be the cause of the CKD is more of a hypertensive nephrosclerosis. So what happened was he presented after his dialysis with dizziness and a feeling of fainting. So he almost fainted. So at the ER, his BP was 80 over 60. The cardiac rate was 135 per minute. The RR was 18 per minute, and the temperature was about 36.8 degrees Celsius. So right off the bat, we're looking at this. He probably doesn't have any infections that's causing the hypotension. Furthermore, he had clear breath sounds, and the ECG was sinus. So that means there's no heart problem that's causing the hypotension, and also the patient is not in respiratory distress. So something must have happened during dialysis. It could be that the fluid status of the patient was miscalculated, or the ultrafiltration volume was too much. And effectively, what happened was it got some of the baseline fluid of the patient, which is responsible for the effective circulating volume. So essentially, he was hypovolemic at this time. So the very important question is, who will you give fluids to this patient, knowing that this is a patient who is in hemodialysis, so has a propensity to develop fluid overload in such in a quick time, and also that you certainly know that these patients are in a strict fluid limited regimen. So are you going to give fluids? And if you're going to give fluids, how are you going to do it, and how are you going to measure it? So this is where your measuring and maneuver will come in. So measuring and maneuver refers to those repeated and serial examinations and fluid boluses that are given to a patient who is in danger of going into fluid overload. So what we did here is we assessed the cardiac size and the contractility. We scanned the lungs for B lines, scan the IVC diameter, and then give fluid in the form of mini fluid boluses, and I'll tell you what it is all about later. And then after those fluid boluses, we scan the patient again to look into whatever response the patient will give. Now, don't have to go into the thousands and hundreds of literature that attests to the role of echocardiography as an effective tool in determining fluid responsiveness. Aside from providing information on structural findings of the cardiac ultrasound, it provides a quantifiable probability of a patient's cardiovascular response to fluids. The application, particularly of POCUS, is not affected by arrhythmias or mechanical ventilation. You can still examine these patients. And because it's something that's skill-based, it's operator-dependent. Now, for your focused cardiac ultrasound, you should look for overt signs of hypovolemia, and this is in terms of chamber size and contractility. If the heart is contracting very quickly, that's probably hypovolemia. If the patient is very small or the chamber size is contracted, that means that the patient is fluid deficient. As in the case of kissing walls, no, as I'll show you in a clip later on. So these particular patients are usually fluid tolerant. Now, for kids, now you can usually do this in the same way as adults. You can get the parasternal long axis view again with the cardiac probe or the sector probe. You can use you can in this view you'll be able to see the LV, the RV, the aortic outflow tract, and the left atrium. So this is how it looks like when you have normal kinetics or normal kinesia, normal heart. As you can see, the left ventricle walls are contracting and thickening to about 2 times its baseline. The anterior leaflet of the mitral valve is actually swinging wide open and almost touching the interventricular septum. The right ventricle also has a concentric contraction. There's no pericardial effusion. So this is what it looks like when you have normal kinesia. Now, compare it to a heart which has hyperkinesia. As you can see from right here, the left ventricle is squeezing really, really hard. No? So much so that the walls are actually kissing each other, the interventricular septum as well as the this part of the wall of the heart right there. If you compare it side by side, you can see the difference between the two. This one thickening to about 2 times its baseline thickness, but from here you can see that the contraction reaches up to the other side of the chamber. So, and also the rate is quite faster than this one. So you have tachycardia and really dynamic squeezing and hyperkinetic squeezing of the chamber walls. Now, compared to hypokinetic, which connotes a patient who is probably fluid intolerant or doesn't need any more fluids or will go into fluid overload if you get fluids, you can see right there, there's minimal swinging of the mitral valve and the cardiac muscle is not actually thickening. And then compared side by the normal kinetic heart, you can see the big difference between the two. All right. Now, when you go to your lung ultrasound, it's a tool that has been validated so many times. No, I think it's much more than the IVC and the cardiac ultrasound. It's a tool that can detect in real time an increase in extravascular lung water. So it's very important in determining fluid responsiveness and tolerance. Now, it can also be used to monitor the response to excessive fluid removal, and we're trying to remove pulmonary edema or congestion in a patient. So lots of studies, as I mentioned, this one just tells us that the B lines, which I'll show you later, allows good prediction of pulmonary congestion by the presence of extravascular lung water. The A lines, which is a marker of normal conditions in the lung or a dry lung, predominance of the A line usually correlate to a pulmonary artery occlusion pressure about 13 millimeters mercury, and that's 90% sensitive and 67% 90% specific and 67% sensitive. Now, the lung ultrasound score makes use of B lines, counting B lines and assigning them a score. The more B lines, the more wet the lung is, and it's usually being used as an endpoint for resuscitation in shock. So also, your GE venue has a B line counter or an auto B line counter, which again uses an algorithm to count the B lines for you. So it's a very nifty software that's bundled in your GE venue ultrasound. So in essence, when you're looking for A lines, these are usually the normal lung ultrasound pattern, and therefore you have fluid tolerant patients, and you have B lines. It connotes wet lung, and you have interstitial fluid accumulation, and therefore these patients will be fluid intolerant. So this is an image or a clip of a lung with A lines, no? So no B lines at all. The A lines are the hyperechoic lines that are occurring in equidistantly from your pleural line right here. These are B lines. Those are B lines are laser-like or watchtower light-like artifacts that emanate from your pleural line and go to the edge of your ultrasound screen. And again, they connote extravascular lung water or fluid in your interstitium. and therefore will signify that these patients are actually overloaded already, and therefore they're not fluid tolerant. Here's the picture, or an image clip of a patient who has pulmonary congestion. So you can see the B lines are a group into one big super B line or mega B line, or what we call confluent B lines. And usually before COVID, this was what pulmonary congestion looked like. But this one, you can also see this in COVID patients who are in ARDS and who have significant infection already or pneumonia. Okay, so I mentioned a while ago that it can be also used as a monitor to determine reversal of fluid overload, or when you're trying to remove excess fluid from the lungs. These are a series of iconic image or clips from a study by Andrew Leteplo, who was also one of my mentors in MGH. He took a series of scans of a patient who was undergoing hemodialysis, who was fluid overloaded at the start, and once he was going through the hemodialysis, as you can see, there is diminution of your B lines until to the last point or to the end of the hemodialysis. There were no longer B lines. So it's a dynamic real-time measure or index for you to determine if your fluid or the diuresis is actually being effective. Now, IVC, we've already discussed this. Now, in kids, you can also do this, like how you do it in adults, subxiphoid area, using the curvilinear or the sector probe, the cardiac probe on a sagittal view. You'll be able to see this one. This is an IVC that is collapsing and therefore fluid tolerant. This is an IVC that is distended or plethoric, and therefore they are fluid intolerant. So you integrate all of those parameters, your cardiac ultrasound findings, your lung ultrasound findings, and your IVC collapsibility. So if you have hypokinetic, dilated chambers, those are fluid intolerant. If you have hyperkinetic kissing walls, those are fluid tolerant patients. For lung ultrasound, if you have more B lines, that's fluid intolerant. And also, in addition to that, if you have effusion, so those are fluid intolerant patients. If you have lung sliding in A lines and no effusion, those are the more fluid tolerant patients. Now, for IVC collapsibility, if you have greater than 50% collapse in inspiration, those are fluid tolerant patients. If you have lower collapsibility, 20% and below, those patients are usually fluid intolerant. So going back to the case, what we did was we gave mini fluid boluses. So why are we giving mini fluid boluses instead of the standard or what is being advocated in most of the guidelines? Now, the mini fluid boluses are usually in the volume of 500 cc's or below. Now, the reason for this is there's a trend to do the less is more approach, mainly because and even this paper just advocates that you can give as low as 200 ml or even below that. The reason for this is large boluses that are being advocated by the guidelines do not usually increase intravascular volume and are usually the evidence that this particular guideline is based on are poor in evidence. There have been several studies that said that in healthy subjects, that fluid bolus, that 30 ml per kilogram, only 15% of that bolus remained intravascularly after 3 hours. It's even more or lesser in septic patients, in which less than 5% of that bolus, the 30 ml per kilogram volume, is retained intravascularly. So where does that fluid go? It goes into your interstitium, it goes into your lung to produce pulmonary edema, it goes to your peripheries, which will produce fluid, peripheral edema or pitting edema. It goes inside your abdomen. It services into your abdomen, which may cause intra-abdominal hypertension or increased pressure. And it will severely compromise blood flow. It will cause hemodilution, and therefore will result to a longer ICU and hospital stay, and maybe even an increase in mortality. So the trend was to give mini boluses in order for you to be able to stop very abruptly if these patients are going into fluid overload. And that's the key to this measure and maneuver. So going back to the case now, so this is the heart ultrasound or the cardiac ultrasound of this patient. As you can see, his heart is quite hyperkinetic. You can see that the left ventricle is squeezing very hard. The walls are kissing each other, and the rate is quite fast. When you go to the lungs only have predominance of A lines. There are no B lines whatsoever. So therefore, this probably means that this patient is fluid tolerant. And you go to the IVC, as you can see, the IVC actually collapses. So again, it's another sign that this patient is fluid tolerant. But remember, this patient is a CKD patient who has a propensity to develop overfluid in a quick time, all right, very quickly, if you give too much fluid. So what we did, and my resident did, was we pre-scan the heart, lungs, and IVC, and we give mini boluses of about 100 ml every 20 minutes for about 5 doses. And in each fluid bolus, we rescan after each bolus, looking at signs wherein the patient is no longer fluid tolerant. So here is the result. At first, this was the baseline of scan of the heart. As you can see, again, squeezing very hard, kissing walls. After the 5 doses of the mini boluses, 500 total in total, you can see that the walls are no longer kissing each other, and the rate is much slower. When you go to the lungs, you can see a solitary B line, one or two B lines in one of the lung sonographic zones. So that was a definite index for us to stop giving the fluids. And when we got to the IVC, it was no longer collapsing. So we've reached this threshold by this point. The patient is no longer fluid tolerant, and we're able to prevent further giving of fluid that may contribute to fluid overload in this CKD patient. So at the end of that 500 mLs total of mini boluses, the BP gradually improved to 110/70. The cardiac rate was slower now at 80s, and the patient was relieved of the symptoms. He no longer had dizziness, and he was feeling so well that he opted not to be admitted. So he wanted to be discharged. And we later found out that he did not have any complications. He did not return to the ER for any of the deleterious effects, and he was quite well on the next session of his daily hemodialysis. So pros and cons of your measure and maneuver. These integrates simple evidence-based POCUS applications. They're easy to do and very simple to learn. You have qualitative indices, even visual clues on which to tell you that to stop giving fluids. However, because of that, the parameters lack standardization. So your mileage may vary. Some will tolerate about 2 more B lines or a lot more distended IVCs. So that's a problem with that. And of course, since it's a skill, there's a skill involved in handling the ultrasound. It's operator dependent. Also, there are caveats on your ultrasound parameters for operating your cardiac ultrasound. It's again based on habitus. It's going to be to affect your handling of a probe, much so also in your lungs if you have lung pathology and also habitus. And your IVC, of course, you have extraluminal, intraluminal factors. If you have diastolic RV failure, valvulopathy, the IVC is not going to be that accurate. Your respiratory pattern also, as we've discussed quite extensively, is going to have an effect on it. So when you're measuring IVC, you should remember that you should be directly perpendicular to it, as well as on the IJ, or internal jugular, because tilting it will cause you to get a much lesser diameter. So that's going to affect your results. So my take-home points for this lecture: POCUS, as you've already learned, is not a perfect tool, but it's definitely very useful in predicting fluid responsiveness. It's non-invasive, readily available, and easily learned. It provides quantifiable indices of cardiopulmonary and vascular response, even visual cues in determining your fluid management. The key is to measure and maneuver, give lower fluid boluses or mini fluid boluses, and then monitor for response. Also, use POCUS for fluid responsiveness in a recent way. There's no point in predicting fluid responsiveness in a patient who is already hemodynamically compromised, like in hemorrhagic shock, hypovolemic shock, or in the first phase of sepsis. Usually, the fluid responsiveness monitoring is reserved for their next fluid boluses. Always test in the setting of circulatory failure. And if sometimes, especially now in this time of the COVID pandemic, most of our patients may be fluid tolerant ultrasonography, but the benefit of infusion may exceed the risk, especially in COVID patients who are in ARDS. Now, they should be putting these patients to be clinically dry. So that's the last slide. I thank you very much for your kind attention. It's quite a long lecture. So I will return now the virtual podium to Kamarul, and I'm open for any questions.
Yep.
Thank you
Thank
very
you.
much.
So thank you, Dr. Babasa. So for now, we'll have a short break, and I'll play two videos. After that, we'll come back and answer your question. I see there are few questions already. So we'll come back in 3 minutes and we'll answer your question. Stay tuned.
When you are determining the cause of shock, you may want to assess the respiratory variability of the IVC. The collapsibility index is a useful tool to evaluate the IVC. But taking all the measurements to perform and calculate the collapsibility index can take too much time. With Venue, if you obtain the IVC view, Venue calculates the collapsibility index for you. Find the IVC, making sure the diaphragm is in view. Press the Auto IVC button. Venue searches for the appropriate place to measure the minimum and maximum IVC diameters within the breathing cycle. Not having to make manual measurements may save you multiple steps and time.
A family cares for you and has your back. The same is true for the Venue family, developed specifically for point-of-care medicine and a wide range of environments. The AI-enabled Venue family is flexible and supports the needs of clinicians across all points of care. An intuitive interface and a common platform across systems help drive consistency from user to user. Automated and advanced clinical tools enable fast assessments to simplify the complex, support your life-saving decisions, and help you monitor patient progress. The Venue family is designed to enable fast patient assessments with AI tools to give you the information you need now. Be confident in what you are seeing, regardless of the environment you are in or the patient you are scanning. Designed for continuity across 3 systems, the Venue family's platform with interchangeable probes facilitates easy onboarding and training for a consistent user experience. Easy to clean, smooth, and seamless services support infection control efforts. The Venue family delivers simple, fast, precise ultrasound for improved patient outcomes.
Okay, everyone. Now we are on the Q&A session, so I'll just go straight to the question. The first question we have is from Dr. Angeline Yap. I think she's from Malaysia. So she would like to know, to measure fluid responsiveness via IJC, is it limited to right IJC or both sides can also be used for measurement? Yes,
Thank you very much for that question, Dr. Ayap. I failed to mention that in the lecture, but most of the studies say that when you're using your IJ, it should be on the right side. So that's where it's usually done. So that's the limitation. You can only use it on the right side. So definitely, the obvious limitations would be if you have a central catheter right there. So that's going to impede your measurement. You better have an alternative to where you can assess fluid responsiveness, maybe through your cardiac or to your IVC.
And then there's a follow-up question. So she was asking, is there any limitation when we are using internal jugular vein to assess the fluid responsiveness?
Yeah, that's well, you can use it just how you just like the way you use your IVC. The evidence is quite good. Definitely, it's a good surrogate for your CVP. I don't know if you believe in the CVP or you use it frequently, But the limitation would be if you have right-sided cardiac pathology, like for example in valvulopathies or maybe in right-sided heart failure. Now, the results of using the IJ to be a marker for fluid responsiveness can be altered. So usually it's meant for patients who don't have right-sided heart problems, and of course there's no physical impediment in measuring the IJ. So those are the only limitations, I think.
Okay.
For patients who have cardiac dysrhythmias, you can go ahead and do this. Even in patients who are mechanically ventilated, you can also use your IJ.
Okay, so we'll move on to the next question by Dr. James Roy.
And
After giving mini fluid boluses, how soon will the effect be reflected in the sonography?
Okay, so there's no really set or standard time in which you'll see the effects. It will depend on the physiology of the patient or in the overall fluid status of the patient. For instance, in our patient who is a CKD patient, no, we were able to see changes up until the fourth fluid bolus, which is about almost an hour and a half from the time we started, because we were giving it every 20 minutes. So it depends on the baseline fluid status of the patient before you'll be able to see any changes in your sonographic findings. So it will vary, definitely.
Okay, so we'll go to the last question here. Role of cardiac output, measurement by ultrasound in evaluation fluid responsibility.
Okay. So I mentioned that a while ago, I mean, the beginning of the lecture, when we are using the aortic outflow flow variation, or when you're using AI of GE venue, the VTI trending. So it's definitely one or more accurate means of determining fluid responsiveness, because you're dealing with the cardiac output. So if you can, you're trained enough or knowledgeable enough on how to do this the old-fashioned way. You're determining the LVOT and then the VTI, and using the formula to compute the cardiac output, then it's very well for you, or very good for you. However, if you are a novice sonographer and not familiar with all of these steps, now you can also use the ones that I described, using the IVC and the IJ and the integrated POCUS parameters. But the role of cardiac output, very accurate for determining fluid responsiveness if you're trained and knowledgeable on echocardiography, definitely. Or if you have the GE venue with you, that's going to be that's
Easy.
going to be very easy for you. I mean, the auto VTI is a great tool, and it's supported by a lot of evidence also.
Okay. I think that's all for the questions. So I guess we can end because I think we overrun our time. So
Yeah,
thank
sorry
you,
about
Dr.
that.
No, it's okay, Dr. Babasa. It was a very informative session. So thank you, Dr. Babasa, for having the lecture with us. So if you guys want to to watch the recording again, so make sure just save the link that you are watching now. And if you have a further question, you can just type on the YouTube comment section. I'll get the notification and I'll send the question to Dr. Babasa. All right. So thank you everyone for joining.
Thank you very
See
much.
you. Yeah. Thank you, Dr. Babasa. See you again. Till next time. Bye bye.
Yeah, I don't wanna slow down, I don't wanna slow down, I don't wanna slow down till I burn out. I just wanna live fast, I don't wanna look back and say I could've done more than I did now. Sometimes it can be hard, yeah, it can be hard, yeah, it can be hard when you grow up. People fill you with doubt, you start thinking about what you're gonna do now. But we only got one chance and got one life to live. And it's do or die, gotta make it count. So lose your worries, let your problems go on until my whole body burns out. I ain't never gonna slow down. I ain't never gonna slow down. I ain't never gonna slow down. waste time, I don't wanna waste time on fake friends. I just wanna get high, just wanna get high, just wanna get higher. Sometimes people will try to hold you back from being who you want to. Don't be questioning why, do whatever feels right, find your passion and fight. Cause we only got one chance and got one life to live, and it's too